Afternoon, and welcome to the second session in our Racial Equity and Advancing Cultural Humility Learning Community, the impact of implicit bias on BIPOC populations with Dr. Jessica Isom, attending psychiatrist, Codman Square Health Center, and clinical instructor, Yale University. My name is Ingrid Paget, and I'm a communications and program strategist with the New England Mental Health Technology Transfer Center. Microphones will be muted during the presentation. At designated times, for example, during our Q&A session, you can use the raise your hand feature to request an open mic. When speaking, be sure to eliminate background noise. You can also submit questions throughout the presentation using the chat. We're pleased to offer the option of closed captioning for this webinar. You can select this option and change transcription settings by clicking the CC Live Transcript button at the bottom of your Zoom screen. Registration affirms your consent to receive an evaluation follow-up link via email, as well as your consent to recording. If you experience any technical issues today, please send me a private chat. Our funding comes from the Substance Abuse and Mental Health Services Administration. The views and opinions expressed in today's session are those of the presenters and moderators, not SAMHSA. The Mental Health Technology Transfer Center Network uses person-centered, affirming, respectful, and recovery-oriented language in all activities. During this session, please ensure that whenever you're contributing to our discussion via the chat or in the Q&A section, that you also use language that is affirming, respectful, and strengths-based. And now I turn the session over to Maria Restrepo-Toro, co-director of the New England MHTTC.
Thank you so much, Ingrid, and what an honor for you to have joined us today. We are absolutely the New England Mental Health TTC, and we are actually a team are committed to advancing race and equity in behavioral health. So the reach is a very important explanation as to why we're here today. We are embracing, and that includes our own team, into a journey. Racial equity and advancing cultural humility for our for organizations is something that's a long journey, but it's a fantastic journey. As we can hear on the inspiration of the song today, we are here together to join the journey wherever you are in your organization to make these services a much better place. This is our second amazing conversation, and we have the privilege to be joined again by Dr. Isom. So if you did not hear her the first time, today we were so compelled the first time that we want to have an even deeper conversation. Our goal to establish a learning community really is for us to engage together continuously in this conversation. We can present a webinar today, and you can access all the webinars in our website, but we know what it takes by personal experience to really become equity, and we want you to invite to continue to join and continue this amazing conversation. So Dr. Isom, I think Ingrid briefly mentioned the amazing honors. She is a board certified community psychiatrist, and she's a clinical instructor at the Yale Department of Psychiatry. She primarily works in Boston, and she's an attendant psychiatry at the Codman Square Health Center with the Boston Medical Center Psychiatric Emergency Services. While completing her medical residence at Yale, Dr. Isom was the chief of medical education as well as the chief resident of diversity and inclusion. Her primary interests in mental health are working toward eradicating racial and ethnic mental health disparities, mitigating the impact of implicit racial bias, and the use of community-focused population health approaches. Now, I think it's very important you understand that our reach is what we hope to achieve today is not only to really give you some interesting intellectual concepts, but to help you have hands-on in what we're going to talk about today. So the presentation is going to be first introduced. She's going to take the floor for a little while, but then we're going to be breaking out in smaller groups, and we're going to have a conversation. So by the end of today, what we really are hoping to do is that you are going to be able to bring Soul 2 back into your community. And we hope that after that, we continue the conversation as we move forward. So without further ado, I'm going to welcome Dr. Isom. Please take the floor. And we are here for an amazing treat and an amazing conversation. So thank you, everybody.
All right, thank you for the introduction. And just to set the expectations, I'll be speaking for about 40 minutes or so, which will leave us plenty of time to have our breakout group discussions, which will be introduced at the conclusion of the talk. The information that you're going to be exposed to during this presentation will inform the conversations that you'll have in those breakout groups. So that will be motivation to pay close attention. So the topic is the impact of implicit bias on BIPOC populations. And as you'll see at the end of our time today, there are future sessions that connect really well to this topic, but also to the exercise that you'll do in your breakout rooms. So I'll spend some time going through some of the terminology related to this concept of implicit bias, and then end with showing how having an understanding of implicit bias can help you come up with better solutions for inequities. So what I'd like you all to do is a series of Chatterfalls with me. I learned this from a social worker, Melissa Dagger, who shares a wall with me at my health center at Cobden Square. And essentially we were doing these virtual events, and we were trying to figure out how do you transition from group activities to Zoom. So one of the things that she came up with was this Chatterfall exercise. And basically what this entails is that you will, as a group, enter an answer into the chat, but you will not press enter. So you'll type your answer into the chat, but do not press enter, and just pause. And then I will say, go, and then all of the answers will fall into the chat together. If you use this strategy with a big group or a smaller group, it accomplishes a couple of things. One, if there's not a lot of safety in the space, or people don't really know each other and aren't comfortable speaking, it can help people engage by answering the question and knowing that their answers will come into the chat together with everyone else's, which is really useful. And two, it's helpful because you have a chance to see what other people are thinking. So what I'm going to ask you to do is do the first Chatterfall with me. And the first question is, name 3 sources of information you rely on for understanding a group of people, whether it be racial others, women, children, the military, Southerners, etc. And remember, because every single time except once, someone pressed enter too soon. So don't be that person. So type your answer into the chat. I'll give you about 10 seconds or so, and then I'll let you all know when we'll press enter together. So what are 3 sources of information you rely on for understanding a group of people, whether it be racial, others, women, children, military, Southerners, etc.? All right, so go ahead and press enter, everyone, and I'll read out for those who are watching the recording or listening on the phone what we have here. So sources of information that have been shared include TV, movies, news, social contacts, the environment that you're in, general observations in different spaces, reading, interacting with group members, medical journals, social media, which is pretty huge, books, again, a lot of observation, some closer relationships like family and friends, coworkers, learning from that group's lived experiences, studying, observing, community organizations, learning from community leaders. Google is huge. I love Google. Personal experience, again, we might be members of these groups, conversations, the internet, more and more. And as you're looking through these answers, there's a lot of repetition. There's lots of some overlap. And I want you to consider these answers when we move to the second Chatterfall. And I'll go ahead and type Chatterfall number 2. All right, so our second Chatterfall question is, and remember you type your answer in, but you don't press enter yet. How reliable do you feel the sources of information are for having a deeper understanding of social groups? So for the answers that you supplied, how reliable do you feel those sources are of information are for having a deeper understanding of those social groups? So I'll give you a few moments to type your answers in and just pause, and then we'll press enter together. All right, so let's see what you got. Go ahead and press enter. So some people are saying not very reliable, probably not terribly reliable. Some are saying very reliable, moderately reliable. There's a spread partially. Some are saying a direct conversation is the most reliable. Others are offering that everyone in the group is an individual and has their own experience. So maybe some of the sources are not as reliable for that reason. Some are saying it can offer you some guidance, but everyone's experiences are different. So there's kind of a spread here. There's some valuing here of lived experience being particularly a unique source, but there's a sense here that for a lot of people, it's not what was listed is not necessarily 100% reliable. And someone else is pointing out that they would want more data and a bigger picture perspective. All right, so we're going to move to our last Chatterfall number 3. And for this question, I'd like you to consider, what concerns do you have about the sources of information that you shared? So we've come to the conclusion that there's a spread, there's some overlap of different sources. We collectively seem to have some hesitation around how reliable those sources are. So now if you could share, what concerns do you have about the sources of information that you shared? So what are some of the risks of using those sources and them not being necessarily always reliable? And I'll give you a few more seconds and then we'll all press enter together. All right, so go ahead and press enter. And we have someone saying, how current is the information? Some are saying the information may be biased. It might be a stereotyped representation. You might want to know if the source itself it contains bias, again, like for example, social media or books. Some people talk about opinions versus facts, right? That will affect how accurate the information is. Some talk about the generalizing of the information beyond just that individual and the challenges with that. And then again, with sources such as media or book representations, people are wondering how much bias might be baked in, how accurate it might be, how outdated it might be as far as the perspective. So this is really helpful. And I could probably just stop here and transition to the breakout groups. This is a summary of the conversation, or at least the talk that you're about to hear, but we'll add some actual language to what we just talked about. And thank you to everyone who participated. That's really helpful to get a sense of where everyone is at for me, and also for you to get a sense of where you are as a community together. So this quote from James Baldwin also pretty much captures what we're going to talk about. He offers that the great force of history comes from the fact that we carry it within us, are unconsciously controlled by it in many ways, and history is literally present in all that we do. And if you think about this, what we're going to be having a conversation about is our collective socialization, and history is baked into our socialization in ways that can be very problematic. So what is socialization? What am I talking about here? So it's a process that introduces people to social norms and customs. We've all been through a variety of these socialization processes, and they're supposed to help us function well in society and help society run smoothly. You know where you're supposed to be, what you're supposed to be doing, to a certain extent, why you're doing it, and what you are contributing to. Who does this for us? Family members do, teachers, religious leaders, peers, books, TV, school, there's a lot of places that we absorb information from. And if you think about, if there's one way of describing it, you're essentially downloading software. You're using the hardware that you have, which is your body and your brain, to absorb this information, download this software, and that software that you're downloading will tell you what to do, how to feel in lots of ways, what to see even in lots of ways as well. So primary socialization can occurs through birth, from birth through adolescence. And then you have secondary socialization, which captures those other processes, like joining an elementary school, for example, or joining a sports team. Those are the kinds of experiences that we have throughout our lives that are separate from that primary experience. You also have a number of groups. So you are socialized into this group. They've set the stage, for example, for how we'll exist together today. There are also organizations that you'll socialize into. And then in a really cool way, really relevant to this talk, there's anticipatory socialization. So you might think about, well, what kind of exposures do I need to become as equity-minded as possible in the work that I do? So it sounds great and dandy to a certain extent, but of course it has its drawbacks, because socialization it's not neutral. The dominant cultural norms, values, assumptions, and beliefs will guide how we socialize each other, what we emphasize and what we de-emphasize. So it's never neutral. And that means that you can input stereotypes, prejudice, and bias into your socialization. And then as an output, you become someone who perpetuates those stereotypes, prejudices, and biases. So that's relevant to this specific conversation today about racial stereotypes. So there's a really helpful text called Race Talk by Daryl Wing Su. That is the source of these descriptors here. And I've shown these in a few different talks because for two reasons. One, it illustrates the point that you can identify probably and throughout your lifetime, sources of information that use these stereotypes, whether it be books, media, TV, family, friends, etc. But you can also identify throughout your life times where you have relied on these stereotypes, and sometimes beneath the level of awareness, and sometimes actually quite consciously, you've relied on these stereotypes to interact with others. So I can give you an example. So last night I was driving home from the clinic, and it was probably 6 p.m. I was in my car and I stopped by a full service gas station, which is where they pump your gas for you. So I was talking to my sister. I was giving the employee, the card. He was pumping the gas, and he came back to hand me the card, and he asked me this question, and he said, is this your car? And then I said, yes, this is my car. And then he said, well, your inspection sticker is overdue, which I appreciated, which is great. But as I was driving away, I asked my sister, I was like, that's kind of strange. Why was the first question, is this my car? Like, do I own this car? And how is that relevant to, the intervention that he was offering, which was, get your inspection updated so you don't get pulled over and fined. So my brain automatically is thinking, what about me, the way that I appear, for example, contributed to that being his first question, rather than just saying to me, hey, just so you know, on the assumption that this is your car, just so you know, your inspection's overdue and you should get that fixed. So I am quite confident that he was leveraging, again, my appearance and all of the things that come along with that to have the need to confirm whether or not this is my vehicle before offering that information. So here on the slide, you see common stereotypes for African Americans and Asian Americans. For African Americans, references such as being hostile or angry, having low skills, being animalistic, undesirable, etc. For Asian Americans, being spies, studious, good in math. Lots of gendered stereotypes here about men and women for this particular group. And I just want you to consider, it's difficult to read these things, it's difficult to see these things, but we have absorbed these things as software because of our socialization. So we have to pay attention to how these are influencing us in interactions and might produce some discriminatory behaviors, even if it's not something we consciously want to be using in our interactions with others. And here are some other descriptors here for Latinos, Latinas. This is language taken from the book. So if that's not an incorrect way of describing the group, I probably would have just put Latinos myself, but or Latinx, and also indigenous peoples. So here we have illegal aliens, foreigners, just greasy, sloppy, poor English. For indigenous peoples, alcoholics, drunkards, primitive, superstitious, all these sorts of things. And what this results is we find ourselves in interactions, and our brains are just naturally designed to categorize and make the world that's very complex into something more simple. So our brain is automatically snatching from our socialization what we have available as data. And I may never have met a person who is a member of this group in my entire life, but I'm already ascribing to them these characteristics that I've been absorbing throughout my life. And then that leads to them having to correct me, for example, in interactions around my misunderstandings about this person as an individual, but also this person as a member of that group. So in a really simplistic way, stereotypes produce prejudice, and we'll talk about the rest of the chain in the next few slides. But prejudice was a really popular word back in the day before I was born. When we talked about racial prejudice, we were talking about racism, and it was often rooted in this interpersonal interaction where I was being declined service, or if I was dating someone, I wouldn't be desirable because I was Black or something of that nature. So that's a term that it's not necessarily changed in its definition, but is used differently. And the way that I'm using it here is that it describes an attitude and also a feeling, an attitude and a feeling. And that attitude is usually negative. The feelings are usually negative as well. And it's not based on any information you have about that specific person. It's based on your prejudgment that oftentimes does not come from actual experience. And you can see actually if the conversations around measurements of prejudice these days are more so measurements of implicit bias. And this is why the language becomes a little bit complicated and why it's much more helpful just to know the story. And the story is that these things are related and they impact how we interact with each other. They also impact how we structure our organizations and the outputs from those organizations. But if you look at these implicit measures, such as like using the IAT, you'll see that people will verbally report less prejudice or less bias, but as measured, it's pretty much the same. And I'll show you an example of how socialization has affected that as well in just a couple of slides. So racial stereotypes contribute to racial prejudice. And then racial stereotypes and racial prejudice produce racial bias, and bias is a preference. And I'll walk you through how children teach us about our preferences because they are modeling our preferences, right? So we're teaching them things, and we are teaching it often through our nonverbal behaviors and our choices about who we interact with as the grownups in their lives. So racial bias is formed at an early age. This is something I think about a lot. I've been thinking about it since before I had a daughter. And now that I have a 4-year-old, it's almost a 4-year-old, it's even more salient because I'm going to have to figure out how to navigate what I'm going to introduce to you on the next slide. So racial bias can be described as a preference, just purely a preference that can be positive or negative. But again, some of the definitions will combine, pieces of stereotypes and prejudice into the bias definition. So the most helpful way to think about it is that it's just a preference, but it's built on thoughts and beliefs related to stereotypes and actions. And actions come from bias, which is actually discrimination, that produce like this favoritism towards some and this lack of favoritism towards others. So when we're often talking about racial bias, it's usually in the negative form, and usually we're connecting it to discrimination, like an actual behavior. And if we think about children, we often are having interactions with our children rooted in our own socialization. So me and my socialization, I've been talking about race and racism, and I have been exposed to racism from very young, right? So my conversations as a child were a lot different. If you look at the literature, the Black parents and their children versus white parents and their children have a very different socialization as a population. So you'll often find in white parent families with their children, they adopt more of a colorblind approach or a color denial approach, which is avoidant of having open conversations about race and racism. And if there are conversations about racial disparities or racial inequities or even racial injustice, the explanations that they offer often discount racism being the cause and often offer culturally racist explanations. So why, aren't there more Black kids at my school, mommy? And a parent might say, well, you need good grades to get into this school, and offer something that continues from there. But also our nonverbal behaviors, who we're around, how we interact with people, teaches our children how we feel about race as well. So this image is a compilation of different sources that detail over young children's lives from birth to about 5, what they have found as far as how they make meaning of race. And at birth, babies will actually not really have a preference by race for specific faces, but once they're 3 months old, they'll actually prefer faces that match the race of their caregivers, which that kind of makes sense. You prefer what you know. Children as young as 2 years old, they actually use race to reason about people's behaviors. And if you think about it, they're teaching us what we do, because we use race to reason, to explain other people's behaviors. And we also use race to explain our own behaviors. I did that because this person was X, Y, and Z. And then by 30 months, most children use race to choose their playmates. And again, this has been fascinating to observe for me as a parent, how much am I contributing to this and what kind of choices is she making? I also wonder about how children feel about her. So I've been to a playground before, for example, and when we arrived and people disappeared, I was like, oh my God, is this something to do with preferences for playmates? And who knows, maybe it was just a coincidence that she was the only Black kid at that particular park. So as far as ages 4 and 5, this is when expressions of racial prejudice often peak based on the literature. And you'll see by 5 years old, when they ask children who are Black and Latinx identified, do you have a preference, for your own racial group or ethnic group? They don't really demonstrate that. But for children who are reaching the age of 5 who are identified as white, they actually at that age have a strongly biased preference in favor of whiteness in those studies. And then by kindergarten all the way to the right, children show many of the same racial attitudes that adults have, again, because we are offering them the software to download that teaches them how they should think, feel, and behave. And also by 5, children already have a sense that some racial groups are higher status than others. So one study that explains why maybe the public conversations have changed, but a lot of our behaviors haven't necessarily changed as much is this one, which measured for a group of 6-year-olds, 10-year-olds, and adults, what were their explicit, their communicated preferences as far as racial groups, and then what were their implicit, measured through the IAT preferences for racial groups. And if you look at the blue bars on the right, you'll see that from 6 years old to 10 years old to adults at the bottom, the bars are pretty much the same. There's not much variation in the implicit preference for whiteness or white people, right? That's across the board the same. But if you look at the top bar graph, you'll see that a 6-year-old is very open about their preferences for whiteness. And these are all white participants. They're very open about their preference. But as a 10-year-old, that openness has reduced. And as an adult, that openness is significantly reduced. And what that is speaking to is socialization, right? So at this point in our society in the United States, it's not okay to be openly racially prejudiced, right? So that explicit preference has changed. But if you look at the implicit measurements, they're the same, which suggests that we're still downloading the same software. It's just we've kind of turned off our open expression of it because of new social norms around how acceptable that is, which means that we still have lots of work to do, even if we're not openly expressing racism. So we've gone through stereotypes, we've talked about prejudice, we've talked about bias and discrimination, and bias, and now I want to move to discrimination. And how I explain this is that discrimination is the actual behavior. So stereotype is the belief, prejudice is the feeling or the prejudgment based on those stereotypes. Bias is the preference, what you prefer or don't, and discrimination is the behavior. So discrimination is considered actions, often negative, taken toward an individual based on their group membership and related stereotypes. So what I wanted to do is capture this progression through these 4 concepts by showing you a video from P and G. It's only a couple of minutes and it'll tie everything together. And what I'd like you all to do while you're watching or just in the moments after is drop into the chat what you see that matches stereotypes or prejudice or bias or discrimination, and we'll see what we all come up with. All right. Yeah. So there's so much there. We could probably talk about just this one video for hours, and I'm sure some of it will come up in the discussions that we have in the breakout groups. But every time I watch this, and I've seen this video probably over 20 times, maybe more than that, because I use it in different presentations, it makes me very sad, actually, because for one, the experiences happen to all of us, right? In this space right here, with everyone having heard my bio, I'm benefiting from all kinds of things. One, I'm here for a talk. Two, my MD, MPH is up there. Three, the space itself is, around a certain sort of spirit. So I'm not necessarily as vulnerable in this space as I was in my car, where I'm very much just a person. And I enjoy being very much a person, right? I'm just Jessica in my car. And I don't have those credentials. I don't have the fact that I'm a speaker. I don't have those other things. So I am just a person who shouldn't own the vehicle that I do, right? So we're thinking about this from our own lived experiences. We're thinking about this for people that we love. We're thinking for this about the people that we work with and how they might experience it in the clinics that we're, working in, or other spaces that we're in. And there is a lot of pain there too. So I want to acknowledge that. And that, again, should inform the conversations that we'll have in the breakout rooms. So just to bring it closer to home, racial discrimination and mental health services. So this is a quote from a text that talks about bias, and the author, or a paper, the author offers that these kinds of bias are a result of our upbringing, where we've grown up, the social structure that we have been a part of, what kind of people and social groups we've been exposed to, what kind of ideas have had an impact on us, and what we see in media around us. And just showing that we are so vulnerable to the software that we are exposed to. But I can't tell you how many spaces I'm in and conversations I'm in, mostly on social media, which for me is a way of accessing just people from all over the world. And some of these conversations, people are operating off of their socialization with no awareness whatsoever. So they'll offer some conclusion that's not rooted in any sort of data, right? And they're very confident in that without interrogating, well, why do I believe this? Why do I feel this? And why do I do this? And again, the whole point of me saying this is that the solution to this is developing a consciousness around the fact that we do download this software, that it does affect us in ways that we may not want it to, because it makes us less effective in the work that we do. So just some examples that you might have heard or even felt yourself or said yourself. So for racial stereotypes in the work that we do, we might assume that all Black clients didn't grow up with both parents. So we might ask a question like, was your dad around, for example, when we have a Black patient, as opposed to asking, well, who were the grownups in your life, which is a question that I use, because who were the grownups in your life is a very, generic question that every single person can answer to a certain extent, that doesn't rely on assumptions. And then you have racial bias. These are preferences. So preferring not to work with Black patients as they are quote unquote difficult. And this might be expressed in very subtle ways within a clinical setting. It might be like through a policy, for example, that might be unwritten, where the Black patients go to the Black people, right? They're kind of diverted over there. Or during our referrals, I'll hear often for people that refer to those in private practice, that they will naturally, for some reason, only get referred Black patients and not get referred anyone else, right? And that's suggesting that there's something driving that, which may or may not be to the benefit of the client or patient. And then as far as racial discrimination, calling child protective services more readily for Black parents, despite the burden of proof being similar across different racial groups, might be a manifestation of that. So I wanted to include a paper from Zescott and colleagues that's really helpful in describing these concepts and how they show up in healthcare across the board. It's a review of the literature that is out there. And the summary of this paper is that essentially when we hold these stereotypes, these attitudes, also known as prejudices, and that leads to preferences in the form of bias, that can lead to discrimination in the form of behavior and how we provide care. And it's not just at the individual level, it's at the organizational level too. What we bake the bias, we bake the prejudice, we bake the stereotypes into our policies, right? That decide, for example, if a patient doesn't show up for their visit, it's because they're a bad patient, as opposed to social determinants of health impacting their ability to come to the clinic. So this is not just interpersonal, individual level stuff. It goes all the way up and it's baked in, and that's important to remember too. So that's a useful paper to read. And then I wanted to include this image. This is from a book called Racism in Psychiatry. It's the new Racism in Psychiatry. There's one from a couple decades ago. This is a new one that came out, I believe, in 2020. Morgan Medlock, who's a colleague of mine, is one of the editors. There's a bunch of chapters by a bunch of really awesome people. And this one chapter is focused on, well, how does racism show up in the clinic? And it offers this just really useful image of capturing how those stereotypes, the prejudice, the bias, all of that produces a difference in experiences in the room more often than not for racialized minorities. So my ability to develop a rapport could be affected, my ability to form an accurate diagnostic impression, the kind of treatments I recommend can differ, and my follow-up plan can differ as well. And one way of just diving a little bit into the rapport piece, there's this paper I came across, which is really interesting, that talks about how racial microaggressions impact the treatment relationship between a therapist and their client. So Constantine interviewed 40 African-American clients who were working with white therapists, and they talked about their experiences and what affected the rapport. And essentially, racial microaggressions produced less satisfaction with counseling and weaker therapeutic relationships. And the number one identified microaggression was colorblind statements, which is why talking about racial socialization, talking about our racial ideology can help us to be better therapists or better psychiatrists or better social workers or better any member of the team, because people are responding to that socialization and ideology that comes from it in ways that affect their ability to remain engaged in care. So that could be leading to premature departures from care, or it could lead to people not wanting to come at all. So I wanted to transition and just offer you all a few quotes from a piece that was from the Institute of Medicine in 2003. It's called Unequal Treatment. Very, very lengthy, well-researched document that's over 600 pages. You can find it for free online. And it was commissioned by the Congressional Black Caucus, and it was asked, the group of researchers were asked to figure out if racism is impacting healthcare. I think it was actually an if question. So it was a whole bunch of people. You had researchers, public health people, doctors, nurses, social workers, patients, psychiatrists, all these people coming together, different types of physicians coming together to answer this question. And one of the things that they did was focus groups. And here are some of the quotes from those focus groups. So I've had both positive and negative experiences. I know the negative one was based on race. It was with a previous primary care physician when I discovered I had diabetes. He said, I need to write this prescription for these pills, but you'll never take them and you'll come back and tell me you're still eating pig's feet and everything. Then why do I still need to write this prescription? And I'm like, the participant, I don't eat pig's feet. Another participant identified as African-American. I felt that because of my race that I wasn't serviced as well as a Caucasian person was. The attitude that you would get, information wasn't given to me as it would have been given to a Caucasian. The attitude made me feel like I was less important. I could come to the desk and they would be real nonchalant, and someone of Caucasian color would come behind me and they'd be like, hi, how was your day? A Chinese participant. If you speak English well, then an American doctor, they will treat you better. If you speak Chinese and your English is not that good, they would also kind of look down on you. They would be kind of prejudiced. And lastly, an African-American physician. Being in a group practice, seeing predominantly African-American patients, I have patients who have seen mainly white physicians in the past. When they come in to visit us and speak with us, something as simple as asking them to sit up on a table and they got a question. What are you going to do? Patient, and the physician offers, I'm going to examine you. And the patient says, oh, my other doctor never did that. And I'd be curious for those in the audience, if you were to hear these stories from your clients or patients, would you believe them or not? Because sometimes it just sounds unbelievable. So there's another report that came out in 2001. And the thing about these is that the years are, at this point, over 20 years old for the one I just, or for this one, and the other one's almost 20 years old. It's still relevant. The data is not that different. So if you were to find a literature review that summarizes racial and ethnic mental health disparities, it's not going to appear any different. So I like showing these because they're really meaty and detailed and can give you lots of insights into how things looked back then and also how they still look now. And across the board, racialized minorities are less likely to have access to services. They're less likely to seek out services, less likely to receive the care that they need, more likely to receive poor quality care, and then more likely to also end services prematurely. And there is a statistic I've seen from SAMHSA that 50% of racialized minority clients or patients don't come back after the first visit. So with that sobering information, what I'd like to transition to now is the solution. And it's really to adopt an equity-minded approach, which we did review in the first conversation that we had. And the point of introducing this is that you really need a different mindset, all of us as a collective, to actually accomplish doing the work of figuring out, like, what are some solutions to the inequities that we see. And an equity mind approach, I feel, as a psychiatrist who does own a prescription pad, is one of the things that I do. I think it needs to be prescribed. And that can be a very complicated topic, especially in a space like this, where oftentimes there's a lot of coerciveness to the work that we do, which can be problematic at times. But I offer it in the form of a prescription because it's something that's more portable. It's something that includes a long list of instructions that are very detailed and kind of gives you a sense of what you would anticipate and how you might be changed in some way that's usually helpful to you, for the most part, from taking that prescription. So I will say one thing I don't have on the slide, but I do want to point out, is that one of the things that comes along with this prescription is a lot of discomfort, and that requires a growth mindset. Another thing that comes with this prescription is a lot of resistance. So a part of this is that, you might readily accept the prescription as someone who's already invested, and you might offer it to someone else who says absolutely not. And they might very much reject the idea of even approaching something in this way. And for all of us, though, either those who accept it or willingly, or who might be a little bit resistant initially and accept it later, it is really hard to adopt an equity mind because it's not naturally how everything is structured. You're often going countercurrent to how things are operating right now. And it takes a lot of work to swim upstream versus just going with the flow and swimming downstream. So with an equity-minded approach, you have a racial consciousness, you understand where you are, where the other person or group is, how that positioning affects their experiences, their lives. You also are committed to being aware of how your meaning making, the language that you use, how you behave impacts others who are around you, namely colleagues, staff, and patients. You're also really willing to be held accountable to history and its present day consequences. So you see inequity as something that you're supposed to help solve. And then you also understand it's not just the personal, it's also structural as well. So a really quick snapshot just to get your juices flowing for the breakout rooms. If someone's not equity minded, what would you notice? They might claim not to see race, so they engage in color denial. They don't really think about disaggregating the data. They don't notice or deny race being a part of why we see the things that we see. They usually attribute it to other things. They don't really see their own personal commitment to equity as being something that makes sense. It's more of something that other people should figure out for themselves. And they often view the workplace as just this really neutral space. And that's in contrast to someone who's equity-minded, who has an awareness of their racial identity, who thinks disaggregated data is actually really helpful for identifying these racialized patterns. They often reflect on how the status quo contributes to inequity, and they're thinking about how to change that to make it a different story. They also themselves are very committed to engaging in that work, and they think about how race, how the software that we download, and how that produces racism actually shapes their interactions at work, at home, everywhere that they are, including in the store or at gas stations. So I want to end with introducing this roadmap from a group of individuals who were underneath the umbrella of the Robert Wood Johnson Foundation. They have produced a really nice roadmap to reduce racial and ethnic disparities in healthcare. And they have a really lovely website called solvingdisparities.org. And after today's presentation, and also posted with the presentation, there's going to be a link to this document. And I'm only pulling out a piece of it because, of course, we can't accomplish everything in one day. But what you'll see is that if you look through the document, all of the information is relevant to all of the future sessions. So it's a way of kind of doing some studying on your own while also coming to this session and future sessions to apply some of that knowledge. So they did a bunch of research, looked at a whole bunch of literature on efforts to address disparities, and they wanted to find what works and what doesn't. So they found what works and what doesn't, which means you can already walk in the door having a sense of what things to do and what things to avoid. And they found that the people who were successful followed these steps, not necessarily in order, but they used these steps along the way to actually reduce disparities, to change the numbers. So you would have to, with your group in your context, link quality to equity. You'd have to create a culture of equity, and the equity mindedness is what that is referencing. You'd also have to adopt an equity-minded approach to diagnosing disparities, which we'll do today. Then you'd have to design the intervention, get people to buy in, and then actually implement the plan that you've come up with and figure out ways of making it sustainable. And what we're going to focus on is number 3, diagnosing the disparity. So if I were to ask you to explain disparities, if I was to ask the public to explain disparities, imagine the answers that we would get. Why are people dying sooner than others? Why do people live in certain areas versus others? Why do certain people not come as often to their appointments or don't pick up their prescriptions? All these sorts of things. And you can see how the software that we download can produce answers that essentially are just racist, right? They don't match the data. They haven't taken into consideration other factors. They often blame the individual for the disparity. And these are just a few questions that are from the resource that will push you towards asking questions that view this through a lens of equity and not through a lens of perpetuating the same old narratives. So yes, you will ask yourself, what's going on with the patient, but specifically you might consider how are they comfortable or not with actually sharing information with me or the people that I'm working with. But you would go beyond the patient and start asking questions about the people providing care. So are we fluent in other languages besides English in how we talk about medical concerns? And then you'd also ask questions about the care team. Is there one available beyond that one provider? Are there patient navigators available to point people to where they need to go? And you'd also have questions about your organization. For example, do they have evening or weekend hours? And then you ask questions about the community. Is it a safe place for those people who live there? What do they think about what's accessible and what's not? And lastly, you'd be interested in policies. And for example, is there a policy for reimbursement around blood pressure cuffs? Because if not, then that would be cost prohibitive for certain patients. So what you're going to do in the breakouts is essentially, you're going to have a scenario and we're going to walk through together and just talk. What might you come up with for answering the question about the root cause of this disparity? And these are ideas. And if you look at the resource, you'll see when you come up with good ideas that are equity informed, then you'll figure out, well, how can I prioritize one of these things to tackle and develop a plan for how to tackle that one piece of this. And then that will contribute to hopefully a difference in the numbers. But for us, it's more of just having a conversation and doing the thinking around generating ideas. But if you were doing this in real life, you would generate ideas and there would be a systematic process to take those ideas towards, developing an actual intervention. So with that said, from that whirlwind, I want to just take a break for a few minutes and show you all a video before introducing the breakout exercise. And this is from the Scan Harbor Performing Arts Academy's Elite Ensemble, and it's a pretty cool video.
Marching on to freedom.
Some closing on what we just heard today. And again, well, first of all, I want to thank Dr. Isom in behalf of the entire team of the New England Mental Health TTC for joining us again. It is an honor to have you and facilitate and really teach us so much today about this. I think this concept of equity mind is something that exactly what we are hoping to continue to embrace as we move forward in this journey. Because I think in order, as we just heard today, in order to grow and to really adapt and become more racially conscious, all of us, in addition to awareness, we want to be able to be willing to be accountable for our work, and that way we can create and design and get a buy-in of all of you in all the communities. So with that in mind, we have designed a space that we call the Diversity Talk. Is an opportunity to extend this conversation, since what we're really looking here is that this is not just another webinar on your list. We really want you. We're here to provide free training and technical assistance around this issue, and we want to create opportunities for all of you to join the small group conversations where you can bring this in addition to what you just heard today. Oh, I went back and this didn't do. I will invite you to invite your teams to join us. This is important. As you learned today, all of us can create a change if we all work together, which is the name of what we're hoping to do. So I think the last one, I'm just going to turn it over to Ingrid.
Oh, thank you, Maria. So we appreciate you joining us today and hope that you can also take a look at registering for upcoming sessions. We'll be looking at engaging in crucial conversations in February. And then we have a whole quarter around organizational bias and transformational leadership, followed by really looking at diversity, equity, and inclusion, and putting those into everyday practices. Our funding today comes from the Substance Abuse and Mental Health Services Administration, which requires us to evaluate our services. Attendees providing their email addresses will receive, within 24 hours of the close of today's event, along with the slide presentation, an evaluation link. All attendees will receive a certificate of participation within 30 days of the close of today's event. We appreciate your honest, anonymous feedback, which we'll provide to SAMHSA, which will assist us in planning future meetings and programs. For more information, contact the New England Mental Health Technology Transfer Center at newengland@mhttcnetwork.org. Please also stay posted to our website, which is listed on this slide, for links to the video presentation and other handouts. And for questions about our racial equity and advancing cultural humility learning community, feel free to contact Maria or myself, and our emails are listed there as well. And we also hope that you enjoy a review of our playlist. We try to open our sessions with interactive videos and tools, promote discussion around the importance of diversity, equity, and inclusion. Thank you for joining us. Have a great day.
I think we want to give an applause to the speaker, Dr. Isom, today for amazing job and conversation. So we hope to see you and to be continuing this conversation with all of you. Have a wonderful day, Mary Roy. Thank you for joining us again. SAMHSA's support is what's making this possible. So it's a pleasure to see everybody.